Hi, welcome back. My name is Nick Kuntz. I'm a neuroradiologist and head and neck imager at Indiana University School of Medicine. And I am back with the third in a series of lectures that I'm recording and putting up on YouTube. These are really for any residents, any fellows, faculty for that matter, but really for the trainees that may be looking for some educational opportunities, particularly as we're dealing with sort of the escalation of this COVID crisis. Nobody really knows what that's going to mean for radiology education and training of our residents and fellows. So, you know, for those of you that may get furloughed, for those of you that may get stuck at home, unable to be at work, I just want to make sure that there are some resources that I can contribute, and these are available for you. So, this is talk 3. I'm back to work today, and you know, just trying to keep up with everything going on with the tsunami that seems to be coming, but did want to take a little bit of time to put some words down and get this up on YouTube today if I could. So this talk is going to be on the temporal bone, and it's going to specifically deal with temporal bone anatomy. And I kind of have an alternative title for this talk. I call it "So Much Stuff in Such a Small Space," and that's because the temporal bone is a pretty small structure. I mean, we're talking about something that is, in general, on each side, somewhere around the size of a stack of playing cards, so a deck of cards. But contained within that, there's really a lot of stuff going on. So just sit back, relax, try to keep up with it. It's on YouTube. You can rewatch it if you'd like. But I'll try to walk through this in a pretty methodical manner, and hopefully this makes a lot of sense. So I still don't have any disclosures to make. One of these days, maybe I'll have some disclosures, but as of now, I have none. I would like to thank 2 people in particular for this talk. First of all, Rick Wiggins, as always, great friend, mentor to me, someone who's taught me more than anybody else as far as learning head and neck radiology and temporal bone imaging. And Rick was kind enough to share several graphics with me when I put this talk together, so thank you, Rick. The other is Chuck Yates, one of our phenomenal ENTs and otologists here at IU, who was kind enough to share some intraoperative images with me as well. So thanks both to Rick and Chuck for the kindness over the years. Okay, so this is kind of our outline. We're going to do an overview of the temporal bone first, and then we'll move into focusing on each of the individual segments. So first up, the 30,000-foot view of the temporal bone. But first, you know, as we're sort of moving into this, the good news is, as I said before, the temporal bone is quite small. The bad news is it's complicated. I mean, there's really no other way about it. I'm not going to sugarcoat it. There's no shortage of anatomy going on here. But once you work on understanding it, grasping it, wrapping your head around it, I think it actually is a quite understandable piece of real estate in the human body. Okay, so the big overview here. So where is the temporal bone located? Well, it's found making up the posterolateral floor of the middle cranial fossa. You can see it sort of in the salmony, peachish color. I'm not really sure what color that is. But you can think of it as really making up the anterior wall of the posterior cranial fossa. And anteriorly, you can see that it's bounded by the sphenoid bone in sort of this greenish turquoise color. And posteriorly, it's bounded by the occipital bone. Along its medial margin, you can see it's bounded by the occipital bone as well, denoted here by the yellow arrow. And then out laterally, it's bounded by the parietal bone. So again, it's sort of this pyramidal bone that's found making up that posterolateral floor of the middle cranial fossa in this sort of salmony color here. And the temporal bone really sort of defines what is the inferolateral skull base. So as we look at this 3D shaded surface display rendering, you can kind of make out the sutures and get an idea where the temporal bone is at. And this is it. I've sort of shaded it in this greenish blue hue here. And I kind of like to think of it as looking a bit like the continent of Australia. I mean, they look similar, right? Similar in morphology. But importantly, the temporal bone is going to encase the bony external auditory canal. You can sort of see we're looking right down the barrel of the EAC where that yellow arrow is pointing. And this makes up the roof of the temporomandibular joint. So if this is Australia, I suppose this is the Great Australian Bight. Sorry, bad humor. But the temporal bone is broken up into 5 distinct portions or segments. So shaded here in this reddish color is the squamosal portion or the squamous portion. There's a mastoid segment in pink. We have a petrous portion that we can't see laterally. This is sort of the internalized component. We'll talk more about that in a minute. There's a small tympanic segment making up the floor of the external auditory canal and some of the back wall, denoted here in yellow. And then we have a styloid component as well, denoted here in the purple. So all of those come together to make up your temporal bone, which again, I insist, looks like the continent of Australia. Call me crazy. Okay, so let's break up each of these portions. So first is the squamous portion, and this is the anterolateral upper temporal bone. And some important considerations for you to think about is this is really kind of thin bone. It's not quite eggshell thin, but it's thin. And so this is also along the lateral side, and that is what's most prone to trauma. So a direct blow to the side of the head can really impact this squamosal portion of the temporal bone, and certainly that's an area where we commonly see fractures. And when you see a fracture there, because of its proximity to the foramen spinosum, you have to worry about associated epidural hematomas. But again, making up that lateral wall of the middle cranial fossa. It also is sort of the floor of the suprazygomatic masticator space, or the temporal fossa. So when the surgeons work in that area and they are dissecting down, once they get deep to that temporalis muscle, making up the floor of that suprazygomatic masticator space is the squamous portion of the temporal bone. And if you look inferiorly, we can see the zygomatic arch. Next is the mastoid portion. This is the inferolateral or dorsal portion of the temporal bone. And this is something that develops, this mastoid process that develops really postnatally. It's very hollow, it's full of numerous air cells. This is sort of a light area of the calvarium, as it were. It serves as the attachment point of the sternocleidomastoid muscle. So whenever you sort of weigh the fact that it's got the aerated bone, it's sort of thin and light, and then we've got that attachment side of the sternocleidomastoid, that's a potential route of spread of infection if you have complicated otomastoiditis. It can pus out there and you get those so-called bezoid abscesses that extend along the course of the sternocleidomastoid. So as we look at the cross-sectional imaging of the mastoid segment of the temporal bone, we have our mastoid antrum, where the yellow arrow here is denoting, or the mastoid cave, and you can see it sort of in the blinking yellow. And then we have the entrance to the cave, or the adytus ad antrum, denoted here with the pink. And that's one continuous chamber that goes all the way to the middle ear cavity anteriorly. And that's our connection to the epitympanum of the middle ear. We also see out laterally, we have this yellow line that's fading away. That's our petrosquamosal suture, or it goes by the eponym of the Kerner septum, if you like to name things after presumably Germans. But that's a surgical landmark. And it's also an important physiologic and anatomic structure because it can serve as a barrier of spread of infection from the middle ear to the lateral mastoid cells and vice versa. Next, we'll talk about the petrous portion of the temporal bone, and this is really our medial portion of our temporal bone, and we call this sometimes the petrous pyramid. But you can see this petrous portion here in yellow, and this is the portion that's not really externalized. You can only see it when you're on the inside looking down or looking outward from the inside. And this has no external or lateral exposure. Now, despite the fact that it doesn't have any lateral exposure, there's some really important stuff that goes on here. It houses the middle ear, the inner ear with the otic capsule, the internal auditory canal, and the Petrous Apex, all things that we'll talk about more in depth further into this talk. As we look at the petrous portion, some of the important landmarks to recognize on this coronal CT, we have our tegmen tympani. This is the roof of the cavity of the middle ear. And that's important because it's really paper-thin bone. So it's a setup point for having potential CSF leaks or cephaloceles, or if you have a bad middle ear infection, you can have transgression through that. You can have egress of pus and bacteria entering into the middle cranial fossa and causing meningitis or meningoencephalitis. As we move more medially, we can see this little bumpus along the roof here. This is our arcuate eminence, and that's an important surgical landmark because that roughly approximates the location of the superior semicircular canal. You're getting a sense of it right here underneath that, and that's something the surgeons look down on. So in this case, this image that Chuck Yates lent me, you can see they've done a middle cranial fossa approach to get down to the temporal bone, and then they look for that arcuate eminence, and that's where they're going to turn their attention and have a good idea where the semicircular canals lay, and therefore they know where some of those important temporal bone structures are without actually having to violate down into them. So that's their entry point that they find with their surgical dissections. As we look along the posterior surface of the petrous portion of the temporal bone, we see our large porous acousticus here. This is the opening to our internal auditory canal. So this internal auditory canal is the area that's just deep to where this yellow arrow is pointing. We look a little bit further posterior and laterally, and we see our vestibular aqueduct, right here denoted by the yellow arrow. And that's going to contain our intraosseous segment of the endolymphatic duct. Now, right about where that yellow arrow lies is where the endolymphatic sac would be, sort of on the back wall here. And it's important to keep in mind that the membranous labyrinth is what's connected to that intradural endolymphatic sac via that endolymphatic duct. Something that we don't really see on CT, but we can get an appreciation for on MRI, and we'll look at that later in the talk. You also, more inferiorly and more medially, have your cochlear aqueduct along this posterior petrous ridge. And this is a little sort of indentation of the bone, but that transmits the perilymphatic space, which is in the membranous labyrinth, out to the subarachnoid space. So this is all contiguous with the subarachnoid space, and that's probably why we see the cochlear aqueduct so well on T2 space or Fiesta imaging or KISS imaging, whatever you do at your shop, because it's part of the subarachnoid space. So as we look here at this diagram lent to me by Rick Wiggins, we can see this sort of cutaway diagram of the membranous labyrinth, and we can see shaded in this sort of periwinkle blue, we have our endolymphatic structures, things that contain endolymph, leading along our endolymphatic duct, or our vestibular aqueduct out to the endolymphatic sac, which is sort of contained alongside the dura. In the white surrounding that is our perilymph, which is, as you can see through the cochlear aqueduct, will transmit out to the subarachnoid space. We'll talk a little bit more about that further into the talk. As we get on toward the inferior surface of the petrous segment of the temporal bone, we can see our carotid canal, denoted here with the yellow arrow in this axial non-contrast CT. And that's going to transmit our internal carotid artery through the temporal bone before it reaches the intracranial space. More posterior to that, we see our jugular foramen, denoted here by the yellow arrow. It's variable in size. Most people have one side that's more dominant than the other. Sometimes it's very, very small. And that's just sort of a developmental thing. As we look inside of that, we see that little red area right here, this triangular shaped structure, and that's our jugular spine, and that's going to divide us into a pars nervosa and a pars vascularis component. So our pars nervosa, denoted here in yellow, is along the medial side, and that's going to contain cranial nerve 9, your Jacobson nerve, and your inferior petrosal sinus. Out lateral, we see our pars vascularis, denoted here in teal, and that's going to contain the internal jugular vein, cranial nerves 10 and 11, as well as the Arnold nerve. Okay, so that's what a textbook will tell you. If you look at what anatomists say and what the surgeons will tell you, it's not always so distinct and divided into a discrete pars nervosa that contains X, Y, and Z versus a pars vascularis that contains other structures. So just keep in mind that's what's taught that's to be contained within these. Reality, it doesn't always work out that way. But just know, in general, those are the important structures that transit through the jugular foramen. All right, next we're going to move on to the tympanic portion, and this is found along the inferolateral temporal bone. You can see again denoted here in yellow. And this is a small U-shaped bone, and that forms most of the bony external auditory canal, particularly the floor and much of the back wall of it. And then we have our styloid portion. This is the inferior extension, sort of protruding off of the temporal bone, denoted here in purple. And this is something that develops postnatally as well, just like the mastoid process. So it's important to keep in mind that this structure that helps to protect nerve structures running below it, like the facial nerve, the extracranial facial nerve, well, that's not really developed at birth. So it does put the facial nerve at potentially increased risk of birth injury because this protective structure hasn't really developed. Okay, that was the overview of the temporal bone. Now we're going to take each of these subsets more in depth and look at cross-sectional imaging. And we're going to start with the external auditory canal. So the external auditory canal, its role is that of sound collection. It sort of acts as a funnel. So like this old-timey ear horn that this gentleman with the wig is employing, it sort of funnels the sound waves down toward the tympanic membrane. So out laterally, it's made up of fibrocartilage, and then as we work more medially, we get to our tympanic bone that makes up the external auditory canal. And as you work your way even more medial, we see our sail-like tympanic membrane at the deep margin of it. So as we look on our CT, you can sort of get an appreciation. The cartilaginous stuff out lateral, the bony stuff deeper to that, and then our tympanic membrane almost imperceptible at the medial margin. One of the critical things to remember with the external auditory canal is its lymphatic drainage goes to the parotid lymph nodes. So we can see this big fungating external auditory canal squamous cell carcinoma. When you see that, be looking at the parotid gland, and sure enough, we have this big necrotic intraparotid lymph node from a metastasis. So looking at our tympanic membrane, it should be almost imperceptible on CT in its native state. That's in patients who haven't had chronic otitis, otomastoiditis, that sort of thing. So almost imperceptible. You can see the yellow line there where it sort of lives, and you can hallucinate that paper-thin margin. It attaches superiorly at the scutum and inferiorly at the tympanic annulus. And there's a pars flaccida component that sits up toward the top, and a pars tensa that sits down below. Next, we'll talk about the middle ear and mastoid. Kind of a lot going on in the middle ear and mastoid. Okay, so the middle ear is broken up into 3 distinct units. And you have, first of all, the epitympanum, or the attic. So you find your scutum, and you draw a line over to your tympanic segment of your facial nerve canal, and anything that sits up above it, sort of looking like the state of Wisconsin here, we have the epitympanum in yellow. Below that sits the mesotympanum, and you find your tympanic annulus and draw a line straight over. Anything that's between that and then the line defined by the scutum and the facial nerve canal, that's going to be your mesotympanum, defined here in red. And then anything that sits below that is our hypotympanum. Okay, so we've got our middle ear. This is sort of inward looking out. We can see lots of structures, stapedius muscle, we've got our ossicular chain, we've got tympanic membrane, we've got facial nerve and branches, we've got our internal carotid artery down below. Start to dissect some of this and look at some of the other structures. We can see, again, here's the oval window. We've got our ossicular chain with the stapes. We've got our stapedius muscle, again, other sound dampening muscle here, the tensor tympani. And we can see branches of the facial nerve with our tympanic segment coming across, our descending mastoid segment down below. So what does it look like on CT imaging? Well, let's look at our boundaries first of all. So superiorly, the middle ear is bounded by the tegmen tympani up above. We talked about that briefly before. Inferiorly, we've got our jugular bulb and our jugular vein that sit below it. Along the medial margin on this coronal image, we can appreciate the cochlear promontory, denoted here by the yellow arrow. Sitting sort of below the cochlear promontory, we have this projection of this little channel. This is our lateral semicircular canal. We'll talk more about that when we get to the inner ear structures. We have our oval window, so sitting just below the lateral semicircular canal, we have our oval window. That's an important structure whenever we talk about our ossicular chain and our transduction of sound. And then as we go just a couple slices beyond that, we can see our round window sitting a little bit lower, which is another important sort of pressure valve, I guess you can say, when we're looking at the inner ear structures. And we'll talk more in depth about the oval window and the round window and the roles that they play in sound generation and detection. So out laterally, we have our tympanic membrane, again, that thin, almost imperceptible, paper-thin membrane. As we look on our axial images, we can see along the medial margin of the middle ear, we have our otic capsule, defined here in yellow. That's the densest bone in the human body. You can see just how much more dense it is than the surrounding skull base. And we have our cochlear promontory out laterally, sort of overlying the cochlea. We have our lateral semicircular canal that I showed you just a moment ago on our coronal images. Again, a really important structure to find, because if you look just below that, you can find your tympanic segment of your facial nerve, and you can find your oval window. And here's our oval window on the axial as we go a little bit further south. That's right where those the stapes footplate would sit, and the stapes is sort of being obscured by the yellow arrow here, but we'll show you the ossicular chain here in just a moment. And as we go a little bit further south, we can appreciate the round window sort of pooching down toward the mesotympanum. I'm sorry, to the hypotympanum. And then again, out laterally, our almost imperceptible tympanic membrane making up the lateral margin when we look on axial CT imaging. As we look anterior to this, we can see the middle cranial fossa is what sits anterior to it, and posterior to the middle ear, we have our mastoid air cells. So let's talk about the epitympanum a little bit, because that contains a lot of important structures, and the ossicular chain is one of them. So as we look here on this axial image, sort of close to the top of the epitympanum, we see the head of the malleus. It sort of looks like the ice cream, which sits on top of the ice cream cone, which is the short process of the incus, and it gives us that ice cream on ice cream cone appearance. If we look just sort of along the posterolateral margin of that short process of the incus, we see this little bit of density extending out laterally. That's your posterior inguinal ligament. There are multiple suspensory ligaments that hold the ossicular chain in place, sort of like the strings on a marionette, and this is one of them you can see quite readily when you go to look for it. So this is our posterior inguinal ligament. It has a lateral slip. It also has a medial slip, which we don't really see very well in this image. This is an axial CT image on the contralateral side, where I'm showing you the anterior malleal ligament. So heading from the head of the malleus anterior to the tegmen is the anterior malleal ligament. You also have a lateral malleal ligament that extends out laterally. Again, almost imperceptibly. These are teeny tiny structures. And then on the coronal image, we can see a superior malleal ligament that attaches to the head of the malleus, taking it up and sort of suspending it from the tegmen above. And then we also see our lateral epitympanic recess, so-called Prusac space, which sits just deep to the scutum, between the scutum and the ossicular chain. That's an important place to look when you're looking for those pars flaccida cholesteatomas. Just another couple words on the ossicular suspensory ligaments. These should be almost imperceptible, just like I said the tympanic membrane should be. When you see them too well, particularly in a patient who has an underpneumatized and sclerotic mastoid like this, that's sort of keywords that they have chronic otomastoiditis, we're seeing these way too distinctly. So this anterior malleal ligament, this posterior inguinal ligament, that's the medial slip of it, this superior malleal ligament above, those are way too dense. That's a patient who has tympanosclerosis. So when you see those ligamentous structures too well, particularly in the setting of conductive hearing loss, particularly in the setting of someone who has chronic otomastoiditis changes, be thinking about tympanosclerosis. It's a common diagnosis. We see it a lot. Be on the lookout for it. All right, moving on to the mesotympanum. So the mesotympanum is going to contain the manubrium of the malleus, which we can see right here. And as we look on our CT imaging, we can see that manubrium sort of butting up against the tympanic membrane. We take another slice away from that, and we can see the long process of the incus extending downward. And then we can see our stapes pointing over toward the oval window. We can see these structures on the axial CT imaging as well. So as we have our long process of our malleus, our long process of our incus, we work our way south, still seeing the long process of the malleus, the long process of the incus. Now we're getting down to our stapes. So we can see sort of the head and the neck of the stapes here as well. If you look carefully, you'll also see those tiny sound dampening muscles. There's two of them. There's the tensor tympani, which is denoted here by the yellow arrow, and that's going to be going from this cochleariform process, extending out laterally, sort of in a horizontal plane, out toward the long process of the malleus. And then we can see it again on the coronal image. Again, here's our cochleariform process. You'll see this if you look for it on every single temporal bone CT, but this is our tensor tympani, innervated by cranial nerve V3, one of those sound dampening muscles. We also have our stapedius. This one's a little bit harder to see, but you can recognize it by finding your pyramidal eminence and look for this little tiny structure that projects forward toward the stapes. That's our stapedius muscle, and that's innervated by cranial nerve 7, seen best on this axial non-contrast CT image, right at the tip of the yellow arrow. And again, that sort of erupts out of the pyramidal eminence. I think of that as looking kind of like a volcano, and what erupts out of it is going to be the stapedius muscle. All right, look along the back wall of the mesotympanum. I mentioned the pyramidal eminence. This is it right here, denoted in yellow. You can see it's sort of hollowed out, and that's where the stapedius muscle comes through. We also have our sinus tympani that sits medial to that, denoted here in red. That's a surgical blind spot. So when they're going in looking for residual or recurrent or even areas involved with cholesteatoma, with their scopes they can't make that 90-degree turn and look very well along the back wall. So that's an important place. As a neuroradiologist and head and neck imager, you need to turn your attention and look to see if there's fluid or soft tissue or erosions. Now sitting out lateral to the pyramidal eminence, we have our facial nerve recess, denoted here in teal. And that sits right in front of the descending mastoid segment of the facial nerve, which is this round thing that's sitting just deep to that. Okay, some words about the ossicles. So within the mesotympanum, we have portions of the ossicles, and these are 3 very tiny bones. And don't take my word for it. Here they are sitting on top of a standard issue US dime. You can see these are quite small. We have our malleus, the club. We have our incus, which looks like an anvil. And we have our stapes that looks like a stirrup. And those come together at 2 distinct joints. We have our incudo-malleal joint, denoted here by the yellow arrows, and we have an incudostapedial joint, denoted here by these yellow arrows. And those are potential areas where you can have potentially fractures or disarticulations or dislocations in the setting of trauma, but also in patients with chronic inflammatory changes in the middle ear cavity, you can get ankylosis or tympanosclerosis involving these joint spaces as well. But these all come together to form a continuous chain that starts at the tympanic membrane out laterally. It forms a continuous chain all the way through the middle ear to the oval window. So as we look at the ossicular chain, something that it's quite hard to appreciate on CT imaging, and frankly I think to some degree people hallucinate these findings, but you can see them if you look very closely and if you have very high quality imaging without a lot of pathology going on. But the ossicular chain is not just those 3 bones. Each of those 3 bones has specific anatomic structures that jut off of them or specific components. And you can see them, and you need to be looking carefully for them. Just know that they can be challenging, and if it's not good imaging, you may not see it well. Okay, so the malleus. Kind of magging up on the malleus, we can see it has a head. There's an anterior process. There's sort of a lateral process that juts sort of out lateral against that tympanic membrane. We're not seeing it well. And then here's our manubrium that we mentioned before that heads south and really butts up against the tympanic membrane. The incus, as I mentioned before, has a short process. That's the ice cream cone that we see on axial CT imaging. It also has a body and a long process that heads south, coursing through the mesotympanum. And then it takes this little kind of curve. There's a little curvature at the tip here, and that's our lenticular process. And that lenticular process is where we have the incudostapedial joint. So we have our incudostapedial joint where it joins up, the lenticular process of the incus joins up with the head of the stapes, or the capitulum of the stapes. You can see the yellow arrow pointing at that. There's a neck to the stapes, and then we have crura, an anterior and a posterior crura, and then eventually we see our foot plate, and the foot plate is what sort of sits right up against the oval window. So as we look on our coronal CT imaging, we can see our malleus. Rolling forward, we see the incus, and then we see the stapes projecting over toward the oval window. We can also see these structures nicely on our axial CT imaging. Here's our head of our malleus, our short process of our incus. We roll our way south, long process of the malleus, long process of the incus, sitting posterior to it. Go another slice down. We're still at long process of the malleus. Here's the long process of the incus. And now coming into visualization is the head and neck of the stapes and a little bit of the stapes crura. Go a little bit further down. We can still see long process of malleus, long process of incus, and here we go, anterior and posterior crura of the stapes, sort of butting up right by the oval window, just next to the vestibule, and we'll talk about the vestibule here in a few minutes. But what's the purpose of all this? Again, I said it's a continuous chain from the tympanic membrane out laterally, all the way to the oval window medially. As the tympanic membrane gets buffeted by these sound waves, it jiggles. It's kind of like a sail, and that's going to cause a drumming effect that wiggles the ossicular chain. That ossicular chain acts as a plunger at the oval window, where that sound wave gets converted from acoustic energy to mechanical energy through a pistoning effect, and then it becomes transmitted through hydraulic means once we get to the inner ear structure before it gets converted to effectively an electrical energy source. Okay, let's talk about the hypotympanum contents. Fortunately, not a lot happening here. This is simply a shallow trough along the floor of the middle ear. It contains air, and that's it. Okay, so moving on to the mastoid, we've sort of mentioned the mastoid a little bit. These mastoid air cells that are continuous to the middle ear itself through the mastoid cave and the entrance to the cave. So here's our mastoid antrum, our mastoid cave, and we have our additus ad antrum, which is the neck by which it transmits and connects to the epitympanum. And again, I said we've got our Kerner septum that sits out laterally, an important surgical structure, and also important for potentially limiting the spread of infection from the middle ear to the mastoid and vice versa. All right, the next portion of this talk is going to focus on the inner ear. And so we'll first start off by talking about the bony labyrinth, also known as the otic capsule. So here it is in yellow, as I showed you before. And this, again, is the densest bone in the human body. And you want to look at it carefully and make sure that it's uniformly dense, because some pathologic states, like otospongiosis or fibrous dysplasia, may change the density of that bone. But this is an important structure because it houses the membranous labyrinth within it. So that sort of gives form to the cochlea, denoted here in yellow, the vestibule, the semicircular canals, of which we're just seeing one right here, the vestibular aqueduct, and then out of plane of this is the cochlear aqueduct. So the membranous labyrinth is housed within the bony labyrinth, and it consists of fluid spaces and soft tissues within the otic capsule, and that includes the vestibule that we see here, the semicircular canals, of which you have 3. We'll talk more about those. The cochlea, the spiral structure here involved with hearing. We have our endolymphatic sac and our endolymphatic duct. And then there's also the cochlear duct, which is out of plane of this view. So as we look at our bony labyrinth in this nice diagram that was lent to me by Rick Wiggins, you can see sort of the cutout that we have going on here at the oval window. But as we dissect away these bony structures, you can see that it's filled with chambers. We have this spiral chamber that's the cochlea. We've got our vestibule in the middle. We've got our semicircular canals sort of on the left side of the image. And each of those are filled with specific fluid-containing structures. The cochlear canals and channels, the semicircular canals, and the vestibule. And we'll talk more about each of those here momentarily. I mentioned I'd say a few words about endolymph and perilymph, and well, here they are. So endolymph is a potassium-rich fluid, and it's contained within the membranous labyrinth. It's continuous out to the endolymphatic sac via the endolymphatic duct that runs through the vestibular aqueduct. Perilymph is sodium-rich fluid, and this surrounds the membranous labyrinth within the otic capsule, but it's sort of external to it. So we have all these bony structures that form all of these canals and chambers. Contained within it are all these sacs that contained the endolymph, and surrounding that endolymph is another sac-like chamber that contains perilymph with sodium-rich fluid. And that perilymph is continuous out to the subarachnoid space via this cochlear aqueduct. And we see that pretty nicely on the heavily T2 weighted images. How do I keep in mind one is potassium and one is sodium? It's pretty hard, but you know, the one trick that I have to remembering it is N is closer to P in the alphabet and K is closer to E. I don't know, maybe you have a mnemonic. I just try to remember it that way. Okay, so the vestibular aqueduct, something you always need to be looking for on your CT imaging. This is the vestibular aqueduct right here. It's sort of along the posterolateral margin of the posterior petrous ridge, and we see this channel denoted here by the yellow arrow. And it should be relatively small. They always say a nice rough measurement is it should be as small or smaller in diameter than the semicircular canals. And I'm not a pediatric head and neck imager. That's good enough for me. But if you like size criteria, they have been defined. It should be less than 2 millimeters here at the operculum. And if you sort of work your way inward, it's going to point down toward the vestibule, and you can see it gets more narrowed. At its midpoint, it should be less than 1 millimeter in diameter. So you can use those measurements if you'd like. And one of the things that I think is helpful is when you look at it on MRI, this sort of falls under that same category as it should be almost imperceptible. If it's too big, if you see it too well, here's an example of it being too big, you need to start looking for other inner ear abnormalities like an IP2 or an incomplete partition type 2 anomaly when you see that enlarged vestibular aqueduct. An enlarged vestibular aqueduct is a finding that is associated with sensory neural hearing loss, and it's something that the otologists want to know about. The cochlear aqueduct is boring, and that's fine. I'm okay with boring. So there's not a disease that's specific to it. So like the vestibular aqueduct has some things that are specific to it, like the large vestibular aqueduct anomaly, or potentially an endolymphatic sac tumor, which can be seen by itself sporadically or in the setting of von Hippel-Lindau. But those are things that are specific to the vestibular aqueduct. The cochlear aqueduct has no such thing. Certainly it can be involved with tumors, metastases, destructive things involving the skull base and temporal bone, but there's not something that I know of that sort of is trophic to it. But this is found inferior and parallel and sitting maybe sometimes more medial to the internal auditory canal. You can see it readily on CT and MR imaging. So here it is on an axial temporal bone CT, and this is what it looks like on a heavily T2 weighted MRI. This is a T2 space in the axial plane. And it should be very T2 bright because it's continuous to the subarachnoid space, so it should follow CSF signal intensity. Next is the vestibule. This is an organ that's used for detecting and interpreting balance and equilibrium. And so here it is in yellow. You can see it in this axial plane in yellow. And it contains two otolithic organs. The first is the saccule, and you can see that sort of rounded saccule right there that's sort of in the vertical plane. And this is for detecting linear acceleration and head tilts. And then it has the utricle, which is seen in the horizontal plane, denoted here with the yellow arrow. And this is also for detecting linear acceleration and head tilts, but in that horizontal plane. When you look within the vestibule itself, you see this just a little bit smudgy area that's a little bit T2 dark. This is your macula, or the spot, and that contains hair cells, your otolithic membrane, and your statoconia. So here's a diagram of what those are. So we have our hair cells, we have our otolithic membrane, and then we have our statoconia, these little rocks, these ear rocks, if you want to call them something, sitting above it. And so that otolithic membrane sort of acts like jello, and you know how jello jiggles when you shake it? Well, so does this. And so whenever you have some sort of this change in linear acceleration, it causes jiggling of that otolithic membrane. And you can see those rocks help to act like sort of like weights, like fishing weights or whatever, that sort of cause a little bit of inertia changes. And so when you have that jiggling back and forth, it triggers those hair cells to depolarize and send that neuronal impulse and transmit those changes in linear acceleration and head tilts. Next are the semicircular canals, and those provide sensory input regarding rotational forces. So you have three semicircular canals. You have a superior, which sort of runs in the sagittal plane. You have a lateral that runs in the transverse plane. And you have a posterior that runs more in the coronal plane. And where the posterior and the superior semicircular canals come together, they have sort of a uniform stalk-like attachment. We call it the crus communis. So that has you can sort of recognize them by the crus communis. But if you look carefully, you see these little bubbles, these dilatations sort of at the attachment points of the different semicircular canals, and these are the ampullae. So within each ampulla, you'll have a cupula and hair cells, and this is what it looks like. It looks kind of like an onion bulb or something like that. But it acts very much like what we just saw within the vestibule, because we have that jiggling in the hair cells that cause the depolarizations, which help us to detect these rotational input changes. So in this GIF, you can see, just depending on how you're moving your head, it causes the fluid to swish about in different chambers, and that triggers those hair cells at the cupula, and those neurological impulses are coded based upon those rotary motions of the head. So the semicircular canals should look low density on CT because they're part of the membranous labyrinth. They contain fluid, and you can see that fluid signal intensity on MRI. That's something I always look for on my T2 space or KISS or Fiesta sequences. You want to make sure that that fluid signal intensity is preserved. When you start losing that fluid signal intensity, you have to worry that something is going on inside of it, whether that is someone who has hemorrhage, who's bled into their semicircular canals, somebody who has like a tumor, like a schwannoma, maybe it's somehow grown up into there, or you may have enhancement within it, which would clue you in that you're dealing with infection or inflammation. So here's what our lateral semicircular canal would look like on a temporal bone CT, the image on the left. We can see this lateral semicircular canal, it's low density. Look at this axial T2 space, same patient, same plane. You can see this, this nice fluid signal intensity lateral semicircular canal pooching off of the vestibule medially. Here's a coronal CT and a coronal T2 space image, just showing you that lateral semicircular canal. Again, it's low density on CT. It's fluid signal intensity on MRI. That's its normal state. Again, I want you to recognize that relationship of the lateral semicircular canal and the coronal imaging. Sitting below that, the tympanic segment of the facial nerve, and then more inframedial, we see our oval window. And here's our superior semicircular canal on the axial CT image. We can see two dots. We're kind of catching it in two different points. We see that same relationship on this heavily T2 weighted sequence here. If you want to interrogate that further, you can image in that plane or do a reconstruction in that plane. Connect those two dots of the superior semicircular canal, and that gives you your short axis temporal bone view. So sometimes we refer to this as the shoot the hoop view on the CT, but this is a nice way of laying that superior semicircular canal out and looking to make sure that it's not dehiscent. Sometimes you get dehiscence of the bone overlying that. That can set the patient up for a Tullio phenomenon. If you clap or cause a loud noise, it can induce vertigo. That's a feature of a third window phenomenon. And then you can see on the T2 space image just how fluid signal intense rich this is. Always be looking for that preserved bright fluid within the semicircular canals, as well as the other structures within the membranous labyrinth. And then we can see our posterior semicircular canal in the axial plane. We're catching in a couple different spots, but again, it's T2 bright. Always look for that fluid signal intensity on your fluid-rich sequence. Okay, next up, the cochlea. The cochlea is a spiral-shaped cavity that's sort of rotates and forms around the modilus, this bony structure in the middle. And your cochlea is going to have three turns: a basal turn, a middle turn, and a much smaller apical turn. And the middle turn is smaller than the basal turn, so it sort of gets narrower as you go toward the top. It looks like a snail shell. So the cochlea has three distinct chambers. You can see those nicely within this, this graphic that was lent to me by Rick Wiggins. You can see up at the top we have our scala vestibuli that contains perilymph. At the bottom we have our scala tympani, which contains perilymph. And then in the middle we have our scala media, which contains endolymph. So as I showed you before, that perilymph sort of sits on the outside, the endolymph on the inside. Well, our scala media is our only structure, our only chamber within the cochlea that contains endolymph. The scala media also contains the critically important organ of Corti. And the organ of Corti contains the hair cells. Hair cells are important for inner ear structures. The other hair cells I've shown you before are used for coding rotational forces and head tilt kind of forces. These are used for coding hearing. And so whenever you have a fluid wave that jiggles these membranes, hair cells that are specific to a specific frequency get triggered to depolarize, and they send their pulses down into this spiral ganglia that lives in the modilus. So as you can see, these have been triggered, and it's sending those neurological impulses down to the spiral ganglia. So in a very diagrammatic manner, this is sort of what happens with sound transduction. So as we look at this this structure, and this is sort of adapted from something that Rick Wiggins gave me, you can see that we've got two holes. So our middle ear cavity would sit out sort of on the left side of the lateral margin of this. And we have here at the oval window, we have our stapes foot plate and our crura. We can see our unwound cochlea here. It's got three distinct chambers. It's got a scala vestibuli, which sort of at the apex wraps around and communicates with the scala tympani. And those are, again, containing perilymph. And then we have a chamber in the middle, denoted here in this greenish color, that is our scala media, and that contains endolymph. And within that scala media, we have our organ of Corti with all of those hair cells. And again, each of those hair cells is going to code for a specific frequency. And it's sort of like the keys on piano that work from low frequency to high frequency. So whenever we have that pistoning effect at the oval window by the stapes, that's where we sort of transition from having a mechanical force into a hydrostatic force. We have a pressure wave. And so we jiggle that. We have our output at the oval window because we need to have some sort of a membrane to transduce that force, because otherwise you're pushing against an enclosed space and it doesn't transmit. But as that acoustic wave gets transmitted through the scala vestibuli and scala tympani, it's going to cause the scala media to jiggle, and it's going to tickle those hair cells at different frequencies, and those hair cells are going to depolarize and send their nerve impulses down to the spiral ganglion found within the medullus. So just one more image here to sort of show you in a very diagrammatic sense what's happening. We have this pistoning effect. So when the stapes footplate pushes in, we have sort of an outward buckling at the oval window that allows that fluid wave to transmit. And then it's going to trigger, through jiggling these membranes, certain frequencies. And each, you'll have hair cells that are specific to that frequency that get triggered to depolarize. So as we look at this electron microscope, we can see these hair cells along the cochlea. But as I said before, these are distributed in a very somatotopic distribution, so that we have at the apex our low frequency hair cells, and sort of at the basal turn we have our higher frequency hair cells. And so that's how we differentiate different frequencies, because different hair cells get triggered based upon the conduction of that fluid wave. So what does the cochlea look like on imaging? Well, on CT, again, it's sort of a low density structure, but we see that snail shell kind of look. Centrally, we have this bow tie shaped bone density. That's our modulus. And as we go back, you can also see that this is a fluid sensitive sequence, and you can see all this bright fluid. And we can even make out those chambers within the cochlea as well on heavily T2-weighted imaging. So looking at the internal auditory canal, because that's where the cochlea sits above, we can see our modulus, this sort of dense bone, this bow tie shaped bone within the middle of the cochlea. We have our spiral ganglion here, and then we have our cochlear nerve, our cranial nerve, the cochlear nerve, which receives all of that sensory input, and that's going to travel within the internal auditory canal. Now, importantly, that's not the only structure that travels within the internal auditory canal. We have other nerves as well, which we can see in this diagram here, and we'll talk more about in the next slide. So as we look on our T2 weighted imaging, we have our axial 3D T2 space, and what I've done here is I've created a multiplanary format in this plane of the yellow line here, and you can see in sort of this oblique sagittal image, we have what looks like sort of a smiley face on its side, and we can actually see those specific cranial nerves within the internal auditory canal. And there's that famous mnemonic that everybody knows. Okay, so as we look at this, we've got on the left side is anterior, on the right side is posterior. We know that because we see our cerebellum back here. But we remember 7 up, coke down. So cranial nerve 7, the facial nerve, sits superiorly and anteriorly within the internal auditory canal. So here's our facial nerve. And then we have coke down, so our cochlear nerve sits anteriorly and inferiorly, so here's our big cochlear nerve. And then we're going to have our vestibular nerve, which sits more posteriorly, and there's a superior vestibular nerve and an inferior vestibular nerve. So as we can see, sort of in the upper outer or upper posterior quadrant, we have our superior vestibular nerve, and in our inferior posterior quadrant, we have our inferior vestibular nerve. And then we also have a vertical bar and a horizontal bar that help to separate these all out, sort of like a tic-tac-toe board or something. Okay, so let's talk about these cranial nerves again. Within the internal auditory canal, we've got on the sagittal oblique T2 space image, again, the left side of the image is anterior, the right side of the image is posterior. We can see upper anterior is the facial nerve. We have our lower anterior, which is our vestibular cochlear nerve, or specifically our cochlear nerve, denoted here by the yellow arrow. We can also see our superior and our inferior vestibular nerves, which sit more posteriorly. Now there's some bony landmarks that if you look carefully on CT you can recognize, and I sort of showed you that horizontal crest on the diagram. Well, as we look on our coronal bone CT image, we see this little bony shelf that projects out. That's going to be our horizontal crest. So our facial nerve and our superior vestibular nerve sit above it, and our cochlear nerve and our inferior vestibular nerve sit below it. As we look on the axial imaging, we can appreciate this little teeny tiny vertical crest, also known as Bill's bar, an eponym, Bill bar, and that sort of divides it into an anterior and a posterior component. So sitting anterior to that would be where the facial nerve goes. Sitting posterior to that would be where the superior vestibular nerve lives. As we look a little bit further down, we can see sort of this subtle perforation to the deep sort of posterior and lateral component of the fundus of the internal auditory canal. That's our macula cribrosa, the perforated substance connecting over to the vestibule, where you have the vestibular nerves transiting. And then we can see our large cochlear nerve canal, where the cochlear nerve comes through sort of medial to the modiolus. And then if you look very carefully, you can see this little tiny canal right here. This is our cingular canal, or the posterior ampullary nerve canal. You'll see that routinely if you look for it. So what happens with the auditory pathway after all of that is really beyond the scope of this talk, but just keep an eye on what happens. So we've got the nerves that are receiving sound, the cochlear nerve coming through the internal auditory canal, going down the vestibular cochlear nerve complex, down to the rustiform body here, at which point within the pons we've got areas of decussation, and these nerve fibers will ascend to the thalamic level and then out to the primary auditory cortex. We're going to talk a little bit about the facial nerve, because that's a really important nerve to recognize and understand where it lives and what it does and where it goes. So the facial nerve is a mixed nerve. It has motor components that innervate the muscles of facial expression. It has parasympathetics, which innervate the lacrimal, submandibular, and the sublingual glands for salivary purposes. And then it has special sensory components as well, because it provides taste to the anterior two-thirds of the tongue. And we've got specific brainstem nuclei that live out here in the lateral pons, motor, superior salivatory, and solitary tract nuclei, that code for these, or that are the actual deep brain nuclei responsible for each of these functions, the motor, the parasympathetic, and the special sensory functions of the facial nerve. So again, the pontine nuclei, but then we also have intraaxial segments of each of these nerves, where they sort of wrap around and run through the lateral pons before reaching the cisternal segment. They all kind of come together in the cisternal segment, and you can track it. It sort of sits more anteromedially along that vestibulocochlear and facial nerve complex. As we work our way out lateral, again, we can see this sits more anteriorly, and it sort of enters into the fundus of, to the porus acousticus of the IAC, just anterior to the cochlear and vestibular nerves. There's a canalicular segment of the facial nerve, and we can follow that all the way up to the anterior superior pole of the fundus of the internal auditory canal. At that point, it becomes the labyrinthine segment, and kind of goes through this short maze-like segment of the temporal bone, and it goes up to the geniculate ganglion, at which point it gives rise to the greater superficial petrosal nerve, which we can see sort of coursing anteriorly. And then it swings its way back as the tympanic segment of the facial nerve, running through the middle ear cavity. I've shown you that on some imaging before, and I'll show it again here in a minute. Before it gets to the posterior genu, which we can see out here, takes a posterior turn and heads south as the descending mastoid segment of the facial nerve. Now that mastoid segment gives off a stapedius branch, so you can see that pyramidal eminence, we've got a stapedius branch. And then it also gives off a chordotympany branch as well that tastes to the anterior two-thirds of the tongue. And then it exits out the stylomastoid foramen down at the skull base, and that's going to be our main motor branch of 7 before we get into the pes anserinus, where it breaks up into its respective branches, innervating portions of the face. So let's look on imaging to see what it looks like. So we talked about the cisternal segment, we talked about the canalicular segment. Now we're looking on this temporal bone CT at the labyrinthine segment. So it's where it sort of goes from the anterior superior fundus of the internal auditory canal, and it works its way upward and forward to the geniculate ganglion, the anterior genu here. It gives rise to the greater superficial petrosal nerve, which works its way anteromedial, and then it wraps its way back and cuts across the middle ear cavity as the tympanic segment of the facial nerve, which again sits just below the lateral semicircular canal. We sort of work our way more posteriorly and more inferiorly through the middle ear cavity, and we get to our posterior genu, where we have the descending mastoid segment of the facial nerve canal. From there, it runs more or less north-south, but it's important to look and see its relationship with the sinus tympani. There's the facial recess as well. So if you look very, very closely along the sort of anteromedial portion of that descending mastoid segment, you see where a little tiny nerve is given rise to, and that's going to be our stapedius branch. We can follow the facial nerve, the descending mastoid segment of the facial nerve, a little bit further south. And if you look carefully, we can also see this little tiny hole that's starting to show up along the deep posterior external auditory canal, sort of its junction with the middle ear cavity. And that's going to be where the chorda tympani branch of the facial nerve runs. We go a little bit further down, further south, closer to the stylomastoid foramen, and you can see, actually, if you look carefully, where this chorda tympani branch arises from, this little sort of lateral outpouching, and you can track that little channel all the way back up to where I showed you that chorda tympani branch within the sort of the deep EAC at the EAC mastoid junction. And then again, here's our main descending facial nerve canal, and we get all the way down to the stylomastoid foramen, where we have our mastoid tip, our styloid process coming out anteriorly. That's our stylomastoid foramen. That's where the main motor branches of 7 exit the skull base and head into the parotid space. As I mentioned before, with that tympanic segment, it's going to course through the middle ear cavity below the lateral semicircular canal. So it's a really important relationship to recognize. The lateral semicircular canal kind of looks like the beak of a duck or something. This facial nerve, this tympanic segment, sits right below that. And here's the lateral semicircular canal with the overlying cochlear promontory. This is also in close proximity to the stapes itself. So the stapes usually sits below the facial nerve canal, which sits below the lateral semicircular canal. And if you look just deep to that, that's our oval window. Now this all comes into play in patients who have oval window atresia, in which you have an atresia plate at the oval window, but that's oftentimes associated with an infromedial displacement of the facial nerve canal. In this case, that's sitting right over that atresia plate. So whenever the surgeons go in to repair this oval window atresia and do an ossicular chain reconstruction, they have to know where that facial nerve is at, because what you don't want to do is take a patient who can't hear, send them off to surgery, they wake up able to hear, but now they have an injury to the facial nerve. So anytime you see oval window atresia, the first thing you need to do is try to find that facial nerve and report its location. Let the surgeons know whether or not that is sitting inframedially overlying the atresia plate, because what you don't want to do is send the patient off to surgery risking iatrogenic injury. They may still perform the surgery, but you want to let the surgeons know ahead of time about that risky anatomic structure. All right, lastly, I'll talk about the Petrous Apex quite briefly. Petrous Apex is found in the anteromedial portion of the petrous temporal bone. And about 1/3 of the time, it's going to be pneumatized. We can see these pneumatized air cells. That means about 2/3 of the time, it's not. And it's important because you get some varied pathology that occurs here. You can have infectious stuff like apical petrositis. You can have inflammatory things like a cholesterol granuloma. It's a site to look for cephaloceles. You can sometimes get cholesteatomas and mucoceles forming here. And also an important area to think of vascular things like ICA aneurysms. Really, the Petrous Apex is quite important because of the real estate mantra, location, location, location. So it sits anteromedial to the inner ear. So we can see our inner ear structure, so it's sitting anteromedial to it. It also sits lateral to the petrooccipital fissure, so potentially someplace that could get involved with tumors that involve the petrooccipital fissure, namely skull base chondrosarcomas. Cranial nerve 6 passes right alongside its medial surface. This is where the abducens canal or the Dorello canal is, if you like to name things after people. It's in close proximity to the trigeminal cave or the Meckel canal, the Meckel cave. So pathologies involving the trigeminal nerve can also involve the Petrous Apex. And importantly, as I said before, the carotid canal sits right by it. So lots of really important structures sort of coming together in one location. So here's what it looks like on CT. It may be non-pneumatized, like in this case. So here's our non-pneumatized Petrous Apex. You can just sort of appreciate that close relationship to the internal carotid artery, the carotid canal there. Or it may be pneumatized. Okay, so we can see that pneumatized Petrous Apex here. What does it look like on MRI? Well, there it is, sort of this pyramidal shaped thing at the anteromedial temporal bone. And I think you can sort of get a nice appreciation for some of the adjacent structures here. So we've got our trigeminal nerve working its way up into the trigeminal or Meckel cave. We can also see cranial nerve 6, the cisternal segment. Here's that abducens or Dorello canal. So you can just appreciate we've got important cranial nerves, 6 and 5 that are right here. We also have the carotid artery, which is obviously an important structure that can be involved by pathologies, and so you want to let the surgeons know about that as well. So that's going to wrap things up for this talk. Just want you to take home an appreciation that, yes, you don't need me to tell you this, the temporal bone, it's complex. There's a lot of anatomy going on here. It takes a long time in looking at a lot of these to get familiar with it and to gain confidence in looking at it. But I do think that having familiarity with the temporal bone anatomy really adds a lot of value to what you do as a head and neck radiologist or as a neuroradiologist for lots of reasons. It can help you to more accurately detail the exact location of pathologies. It can be helpful as you try to navigate complex postoperative exams to sort of know where things are or where things should be or where things used to be. And I think it's helpful to understand some of the clinical ramifications of these structures that we talk about and why we talk about them. I do think that among all things that we do in neuroradiology, the temporal bone is really sort of the poster child of lifelong learning because it's something that every day when I look at, I feel like I'm seeing new things or getting a better understanding of the things that I look at. So the more you look at it, and maybe more importantly, the more carefully you look at the temporal bone, the more you'll see. So it's something you'll see stuff, especially the first few years that you're in training, or even the first few years you're out of training, and you're like, well, what the hell is that? I feel like I should have seen this before, and guess what? It's been there all along, you just have never noticed it. Grab a reference book. There's lots of good anatomy books out there. Look these things up when you see them. Make sure you know what things are. I think it's something that you should have a healthy respect for the temporal bone, but don't be afraid of it. I think anybody can do it. Just make sure you take the time to learn. So, as always, thanks a lot for joining in. Really appreciate it. Again, hopefully you're staying healthy, you're doing well, and you're continuing to take care of patients and do the good work you do as we're dealing with this COVID crisis. But hang in there. Things will get better. But again, encourage you to use these lectures to try to at least have some resources in case you're out of the reading room, in case your noon conference schedules get messed up, and give you something to do. I'd also encourage you to follow along on Twitter, where I do a case of the day for IU, which you can follow along at nakuntz@iupui.edu, or you can follow along on Twitter at nakuntz, and there's my email address if you ever want to reach me. So again, thanks for your attention. Really appreciate it. Take care of yourselves.